Good afternoon. I'm Robin Gould. I'm the Pro-Vice-Chancellor of Commerce and Dean of the University of Otago Business School. Congratulations on the launch today of the special issue of the journal. I'm enormously honoured to be included in that special issue and author of the paper on models of governance for integrated healthcare. Now, I draw in that article on both theory and practice of governance for integrated healthcare. Now, the theory covers four different models. That is the corporate governance model, which I'm sure you're all familiar with, democratic governance, which is essentially people being elected to govern a healthcare system, which we have probably the world's most experience with. We've had democratic governance in our country across our 20 regions since the year 2000. Then clinical governance, the idea of bringing healthcare professionals into governance and leadership roles, and then alliance governance, which is the idea that which has been supplanted in the New Zealand context onto the healthcare system. Now, alliance governance is drawn from the private construction industry, and it's based on the idea that if you have, say, a building or a large skyscraper or a bridge being built, you're going to have a range of contractors who all have the same outcome in mind, that is finishing on time and in budget. And so they have to forge an alliance in order to share resources and work collaboratively to ensure that their goals are delivered upon. Now, as I said, we've had this model supplanted into the New Zealand healthcare system, and I'm also the independent chair of the alliance in my part of New Zealand, the southern part of the South Island. And so the paper then describes New Zealand's experience with alliances and draws upon the example of Alliance South. So the paper brings together the mix of theory and practice of alliance governance through the example of Alliance South in New Zealand. Well, all the best with the launch, and I greatly look forward to seeing the issue go viral.
Hi, my name is Patterson, and it was a privilege to have my paper accepted for the special Australasian edition of the Journal of Integrated Care. My paper draws on my lived experiences as a health professional in a range of roles and settings, and more recently as a PhD candidate with the University of Technology, Sydney. I'm hoping my paper engages you to think and reflect on how we capture and understand the value and benefit at the individual level of healthcare. Integrated care is, as a concept, a philosophy, a way of being, and a model, a way of organising, draws on over 25 years of research and health reforms that have looked at the benefits of a population health approach to the way health services are designed, looking at a person-centred, patient-centred delivery model, and organised within an interdisciplinary context. The success of these models is based on a shared meaning or a shared understanding, both within those who deliver the service, but more importantly and as significantly, a shared meaning and language with those who receive the service. Our methods of evaluating the impact or in evaluating what people bring to their healthcare experience are limited and is identified as a gap in the research. This paper explores ways in which we can better evaluate, identify the value that integrated care offers at the individual level of healthcare. I hope you enjoy the paper, and I look forward to your feedback.
Hi, I'm Greg Stewart. I'm the Director of Primary, Integrated and Community Health in Southeastern Sydney Local Health District, a large operational district in the centre of Sydney, 800,000 people and a budget of $1.7 billion. About 3 years ago, Southeastern Sydney embarked on what we called a journey towards excellence, and that journey towards excellence involved the development within our local health district of better systems to allow us to provide quality care to the people we serve and to consider issues of efficiency in the way we provide services and improving health. So in a lot of ways, the triple aim objective. And integrated care was a very important part of that journey to excellence. About that same time, the King's Fund published a paper called Making Integrated Care Happen at Scale and Pace. In my view, a very important paper to challenge operational health services like ours to better implement integrated care across a broad system. In Australia, particularly complicated by the fact that the state-funded health systems provide certain services and the Commonwealth funds, particularly general practice care and some other aspects of primary care. And so we set about working out how to do that, and this paper describes that. The first thing was that we wanted to develop a convincing narrative about integrated care, and for that we used as our starting point the English NHS House of Care, which provides a very nice and convincing model about the kind of aspects and systems that are required to better integrate care. And the paper describes that, how we developed that narrative, and it describes the strategies that we identified to allow us to implement a system for better integrated care across our local health district. And it also describes some of the specific projects that we undertook, an e-referral system, for example, called PRISM, which has proven to be very, very important in influencing the practitioners and the providers in getting involved in integrated care. So far as lessons are concerned, the need for a convincing narrative was a very important lesson, as was the need for partnerships built on trust. And we spent a lot of time developing partnerships with providers and organisations, our fellow health service organisations and the local primary health network. But perhaps to some extent, the most important lesson we learned was a lesson around how we view integrated care, rather than a narrow perception of integrated care as a series of systems to look after people with long-term conditions, rather to think of integrated care more broadly. There's a very nice quote from a paper published by Ellen Nolte and Emma Pitchforth a couple of years ago, where their description of integrated care was that it needs to be interpreted and evaluated as a complex strategy to innovate and implement long-lasting change in the way services in the health and social care sectors are being delivered, and that involve multiple changes at multiple levels. And for us, that's the long game. That's the key thing about integrated care, and I hope that our paper presented that kind of argument in its final form.
Hello, I'm Christine Phillips, and I'm Kirsty Douglas. We're from the ANU Medical School. The question that we want to explore in this paper related to a question of integration of a health service under conditions of great challenges. So the service that we used, the model, was a refugee health service, which refugees in Australia and in many other countries are a population who are subject to many policy changes, and their services are often underfunded and have to change a lot, and the staff are under some stress. So we were interested in how integration occurs in those settings.
And we studied a refugee primary health care centre which has been well established and has survived despite some of those challenges. The centre we studied has general practice, counselling, community development, advocacy and case management as an integral part of the services, so a whole broad range of primary health care services. And we wanted to look at how integration worked and how both the staff and patients that were accessing that service viewed integration, and if we wanted to promote integration in other services, what could we do to promote integration?
Yeah, what could we learn from this kind of a service? And what we found out from the perspective of the patients, it looked like a home, and from the perspective of the staff, it was, the metaphor that was used was that it was like a family. So these are metaphors of safety, really, which is really important for this population. When we talked in more detail to the staff, the thing that they repeatedly said mattered for integration was that they shared a vision about what it was that that service would do and how it would meet the needs of their population. It wasn't essential that they actually integrated on particular clinical cases, but that they were able to share deeply in the mission of this practice. The implications of this for us are that services that are under some stress can actually become quite adaptive with this shared mission, and for our paper addresses the way that this actually functions as a complex adaptive system. We think this has some relevance for other health services working under stress, trying to integrate, and we think it may have relevance for the mainstream population.